In this video, we will review structures of the heart, we'll review the pulmonary and systemic circulations, heart valves, heart sounds, and then we also talk about the cardiac cycle, the electrical activity of the heart, ECGs or EKGs, and then some clinical examples such as cardiac arrhythmias and atherosclerosis. But as a reminder, the pulmonary circulation is the circulation that's done by your right side of your heart, where the right atria receive blood, the right ventricle is going to discharge blood to your lungs for that blood to get oxygenated, and then that'll return to our left atrium. Then that is our systemic circulation, because our left atrium is going to receive blood. It's going to bring it into the left ventricle. The left ventricle will discharge it to the whole body and oxygenate our tissues. All right, so we're going to talk about your heartbeat, the cardiac cycle. And so we have to look closely at our valves, because it is the opening and closing of the valves that cause our heart to beat. And this is going to impact, how blood can be pushed through the heart is via these valves. So to review, our atrioventricular valves are between our atria and our ventricles. So here's an atrium, here's an atrium, here's an atrium, here's a ventricle, here's a ventricle. And so our atrioventricular valves are going to be between those. Try before you buy. So tricuspid valve is on the right side, bicuspid valve is on the left. Try before you buy. And it is when the atrioventricular valves shut that we hear our first sound of our heartbeat. So that lub sound of the lub-dub sound. So this is when there is pressure in our ventricles, and this is going to prevent backflow of our blood into the atria. Remember, in our body, blood flows in a one-way street. So blood flow is going to flow one way and one way only, and we wouldn't want it to go backwards ever. Similarly, we have the semilunar valves. The semilunar valves are called semilunar valves because they look like half moons, and they are between the ventricles and the arteries that they're attached to. They're named after them too. So the ventricle, the right ventricle, is attached to the pulmonary trunk. You have the pulmonary valve in between. The left ventricle here is attached to the aorta. You have the aortic semilunar valve in between. When our semilunar valves close, that is when we hear the second heart sound, the dub sound. And similar to our atrioventricular valves, this prevents backflow of blood. We would never want backflow. And FYI, the try before you buy thing, I didn't say this in the other slide, but the tricuspid valve is called the tricuspid valve because you can see that it has 3 flaps to it, whereas the bicuspid valve is called the bicuspid valve because it has 2 flaps to it. So maybe you've heard of heart murmurs before, but heart murmurs can be produced by abnormal patterns of blood flow. One, it could be caused by defective heart valves, where your heart valves don't close all the way. So that's one way, right? If these valves don't close all the way, there is going to be backward flow. And so when you hear a heart murmur, it just sounds like kind of like water rushing in the background, when that's blood rushing in the background. So this could be caused by heart valves that don't close all the way. It could be caused by septal defects. So remember your interventricular septum, which is this piece right here, or your interatrial septum is just the dividing pieces between the atria and the ventricles, kind of like a septum piercing, right? Is the dividing piece in your nasal cavity. So in an individual with septal defect, they may have a hole between the interventricular septum, which is shown down here, or the interatrial septum. And that would cause a murmur because you wouldn't hear these strong lub-dub opening and closing of the valves sounds because the pressure is going to change. So the pressure would change here because blood from the left ventricle or left atria would pass over to the right, which can impact the opening and closing of the heart valves. Similarly, we have other, clinical examples here. Rheumatic fever is caused by production of antibodies that are going to attack the tissue here. And so maybe they attack the tissue of the aortic semilunar valve, and that can impact the valve function. Or there's something called mitral stenosis, which is going to impact that bicuspid valve, where the bicuspid valve gets thickened and calcified, and the mitral valve is not working as it should, so it's going to impact the blood flow from the left atrium to the left ventricle. So cardiac cycle is the repeating pattern of contraction and relaxation of the heart. On average, the cardiac rate is about 75 beats per minute, so it has a range of 50 to 90 about beats per minute. Someone who is more athletic may be on the lower side of that. Each cycle lasts about 0.8 seconds, and we use the words systole and diastole to discuss this. More so, we focus on the contraction of the heart, or the ventricles, or what the ventricles are doing. But here we talk about them kind of as a whole. And so when we talk about systole just pretty much means contraction. And what it means is when the parts of the heart are contracting. And so the atria contract at the same time, and then the ventricles contract at the same time about 0.1 to 0.2 seconds later. There is a slight delay. Diastole is heart relaxation. And so again, the ventricles are going to relax. And when the ventricles relax, that is when the atria contract. And so, when we talk about systole, diastole, we're usually talking about it in the POV, the point of view of the ventricles, because it's not like the atria and the ventricles are doing the same thing at the same time. So when we talk about ventricular systole, we're talking about the ventricle contraction, and it's not the same time as the atrial contraction. When ventricles relax, when it's ventricular diastole, that is when the atria contract. And it is when there is relaxation of these chambers that they then fill with blood. They don't fill with blood when they're contracting. They're pushing blood out when they're contracting. They're filling with blood when they relax. So when the ventricles relax, they are filling with blood. When the atria relax, they are filling with blood. And whole diastole takes about 0.5 seconds. So again, as I was saying before, when the ventricles relax, which is considered diastole because we're POV of the ventricles here, the atria fill up with blood. And this is called venous return because it's the veins that are filling up the atria. The pressure in the atria is going to cause the AV valves to open. So it will push these AV valves open. And then blood will enter our ventricles. End diastolic volume is the volume of blood in the ventricles at the end of diastole. 80% of the blood in the ventricles are in there before the atria even contract. But when the atria contract, it adds that extra 20% to completely fill up the ventricles. Filling of the ventricles is going to close the AV valves. And then it's going to eject about 2/3 of the blood that is in the ventricles. This is called the stroke volume. The stroke volume is the amount of blood that's pumped from the ventricles during systole, during contraction. About a third of blood is left in the ventricles, and that is called end systolic volume. It's the volume of blood that's left over at the end of systole, after the end of ventricular contraction. When the ventricles contract, so during ventricular systole, the pressure is going to rise in the ventricles. It's going to push the AV valves closed and going to push the semilunar valves open. When the ventricles relax, the semilunar valves shut because of the pressure in the blood in the arteries, and then the atria fill up with blood. The right atrium is filling up with blood from the venous return from veins. The left atria is filling up with blood from the lungs. This is going to push AV valves open, and then blood will enter the ventricles. So what you can see from this picture is that valves are always opening and shutting because of the pressure of blood. It's the pressure of blood pushing these valves either open or pushing them shut. So this graph is a little complicated, but let's just break it down little by little. So as we can see down here, first off, we have the heart sounds. So this is that lub sound, and this is that dub sound. And we've said how the lub sound is when the AV valves close. The dub sound is when the semilunar valves close. This part is in systole. So again, we're always talking about in the POV of the ventricles. So we are talking about ventricular contraction here. You can see that the volume, and we're always talking about the left ventricle also, because that's where more of the action is happening. We're talking about systemic circulation here. So we're talking about how much volume is in the left ventricle. It is going to contract, which causes pressure in the left ventricle to rise, and then that pushes blood out. So number 2 and 3, that pushes blood out of our left ventricle. That causes the volume in the left ventricle to drop. And then we have a lot of volume in our arteries now. And so that causes the semilunar valves to close, and that reduces the pressure inside our ventricles. And now our ventricles are relaxed. Our atria are relaxed for a little bit. Atria are filling with blood as well as pushing blood into the ventricles. And so there's slow volume changes as the atria fill with blood and then the ventricles fill with blood. This will cause a higher increase in volume in the left ventricle. Okay, so if you can remember from anatomy, our heart is myogenic, meaning it is able to send action potentials and excite its own cardiac muscle cells. And it does that really by the main player here is our SA node called the sinoatrial node that's found in the right atrium. So unlike our typical neuronal cells or skeletal muscle cells, it does not maintain a resting membrane potential so that, it depolarizes from this resting membrane potential. Instead, it exhibits a pacemaker potential where there is a slow, spontaneous depolarization by the SA node during diastole. So whenever there is ventricular relaxation occurring, the pacemaker, the SA node, spontaneously depolarizes to allow for the cardiac muscles to excite. It controls the pace of our heart rate. Our SA node controls the pace of our heart rate. However, there are other tissues in our heart that can generate the action potentials too, but they are slower than our SA node. And so our next one here would be our atrioventricular node. And so if your SA node for some reason, didn't work or wasn't effective, or the tissue got damaged for some reason, the atrioventricular node is able to set that pace of the heart. However, it does it at a much slower pace where it would be bradycardic. How the AV node can act as a pacemaker if the SA node isn't working, that is called an ectopic pacemaker. So pacemaker potentials are something that is specific to cardiac, the SA node, cardiac tissue. And what it does is actually a little different. It uses these channels called HCN channels that are going to depolarize our cell and produce these pacemaker potentials. In this cardiac tissue, the resting membrane potential is about -60 millivolts, and these pacemaker potentials are going to cause it to go to a -40 millivolt threshold. That threshold is caused by these openings of these HCN gates, and they are called HCN gates because they are actually opened by hyperpolarization. That's what the H stands for, hyperpolarization. And so this is completely different from what we learned with other voltage gated channels that are opened via depolarization, like these ones over here. This one is opened from hyperpolarization, as you can see on the downstroke here. And then it can also be opened by cyclic AMP, or cyclic nucleotides is kind of what it stands for. And this can be released by epinephrine and norepinephrine. And so what this is trying to say is that our sympathetic and parasympathetic divisions can actually control the pace of our heartbeat by controlling these HCN channels. These HCN channels will open, which will cause depolarization, and it depolarizes by allowing sodium to rush in, which will then reach threshold, and then voltage-gated calcium channels will open, which will cause calcium to rush in and contraction to occur. Then at about plus 20 millivolts, this will cause the voltage-gated channels to open, and potassium will rush out, causing repolarization of the tissue. So action potentials in myocardial cells look a little different. As you can see, there is depolarization here, and it occurs pretty quickly, where sodium is rushing into the cell. And then notice that when calcium rushes, well, I shouldn't say rushes, calcium moves into the cell, it's actually at a pretty slow pace from the extracellular fluid. So it produces this long plateau phase, which kind of extends the length of extends the period of an action potential. This will delay potassium moving out about, however many milliseconds. And then it's at the repolarization that potassium then is able to move out. So this graph over here shows you the myocardial action potential in green, along with the myocardial contraction in red. And so the contraction lasts about as long as the action potential, because it's dependent on what's going on with the action potential for this myocardium contraction to occur. The long action potential produces a long refractory period, and this long refractory period, just like our refractory periods in neurons, that means that the myocardium cannot be stimulated to contract again. And having this long refractory period prevents summation. It prevents summation, it prevents tetanus and sustained contraction. And really, this also prevents the other ectopic pacemakers from setting from exciting or contracting muscle itself, because of these long refractory periods and they're following the pace of the SA node. And so this ensures functioning, efficient functioning as a pump as a whole. So these absolute refractory periods that are lengthy in time allow for the cardiac tissue to kind of work together and prevent summation, prevent tetanus, and prevent these other myogenic tissues to be excited. So conducting heart tissue impulse begins at the sinoatrial node, and then it just moves down from the atria to the ventricles, because that's how our muscle contracts, our cardiac muscle contracts, right? The atria contract, then the ventricles contract, the atria contract, and then the ventricles contract. So it kind of goes from a top-down manner, beginning at the SA node to the atrioventricular node, down to the bundle of His, and then the left and right bundle branches, and then the Purkinje fibers. And so as you can see, it goes from the top of the heart to the bottom of the heart, which causes contraction at the top, contraction at the bottom, contraction at the atria, contraction at the ventricles. An electrocardiogram is one way that we can observe the contraction of atria and ventricles by recording the electrical activity of the heart by measuring ions in the body to the surface. So looking at this graph here, it shows an ECG, which we'll talk about more, as well as the action potential of a myocardial cell. And you have the depolarization with the slow influx of calcium, and that comes in line with the ventricle depolarization, as well as the ventricular repolarization. So there's three distinct waves when you observe an ECG, and this would just be one heartbeat shown here. The P wave shown here is showing you the atrial depolarization, so the atria getting excited and depolarizing. The QRS wave is showing you ventricular depolarization. And by the way, this wave is so much bigger than the P wave is because the atria are way smaller than the ventricles. So the P wave are just the atria, they're pretty small, which is why they only make this little hump of potential. The ventricles, in contrast, are pretty large. They make this huge wave compared. And then the T wave would be the ventricular repolarization. And these are actually shown in the same direction rather than like going like this, because this is going from the endocardium out to the myocardium and epicardium, and then this is repolarization, but it's going from the epicardium to the myocardium to the endocardium in. So they're shown in the same direction as the recorded potential here. And then there's going to be an interval, and then it will repeat again. So here is an image of it. Here you can see atrial depolarization. Notice that it's only half of it is depolarized, half of it is going here. And then when all the atria are depolarizing, it brings that wave back down. And then it shows the depolarization of the ventricles. And notice, you can also look at this from the view of the SA node, the AV node, the bundle of His, bundle branches, and then the Purkinje fibers. And so we're talking about the excitation of those tissues, and it's causing the electroactivity of the heart. The QRS wave over here is ventricular depolarization and then contraction. So depolarization and then repolarization, as we said before, is going in the opposite way, which is why the T wave is in the same direction as the QRS wave. So how do we correlate what we saw with the ECG as well as heart sounds? The first heart sound, the lub, comes immediately after the QRS wave, after depolarization of the ventricles. So after depolarization of the ventricles contract, which close the AV valve, which causes this lub sound. So after this happens, after ventricles are depolarized. The second heart sound is after the T wave begins, so that's after ventricular repolarization. And as you can see here, the repolarization is when ventricles can contract. There is more blood pressure in the arteries at this time, causing the semilunar valves to close, producing that second dub sound. So we're just going to talk about a couple clinical examples. Atherosclerosis is the most common form of arteriosclerosis, which is the hardening of arteries. And, this is a very common disease in the United States. It accounts for 50% of deaths. And atherosclerosis is caused by these plaques, which are called atheromas, which is what athero comes from, that are going to impact blood flow within an artery. They can act as sites for thrombus, which are blood clots. And so whenever you have something like this, there could be buildup of platelets or clotting factors, which can cause a thrombus to occur. Atherosclerosis like this first begins from damage of the blood vessel walls, damage of the endothelium, and this damage can occur from a lot of different things. I think most commonly is perhaps hypertension, which is just high blood pressure. If your blood pressure is high for an extended period of time, it's going to impact the vessel walls. Smoking can have an impact. High cholesterol can also cause this. High cholesterol can cause these atheromas to occur in the first place. Diabetes can also impact the vessel wall. So what you would first see are these fatty streaks where you might observe these like lipid-filled macrophages and white blood cells. So in the intermediate phase, you may see layers of macrophages as well as layers of smooth muscle. So it shows that there was like an immune system response here if there are layers of macrophages within the walls of the blood vessel. Atherosclerosis at an advanced phase has fibrous plaques, so connective tissue and smooth muscle and white blood cells and lipid, which all kind of melt together and form this clot or plug within the blood vessel wall. So cholesterol can be impactful. There are actually two types of cholesterol: low density lipoproteins and high density lipoproteins that are produced in the liver, but they can be taken into cells via receptor mediated endocytosis. And in cells, low density lipoproteins can be oxidized, and that can injure endothelial cells, which can cause this plaque formation. Arteries have receptors for these low density lipoproteins, and so that is why low density lipoproteins can cause atherosclerosis, but high density lipoproteins does not. And so when you go to the doctor and they check your cholesterol, they check both numbers, LDLs and HDLs. And it's usually, you want to make sure that your LDLs aren't too high, because these LDLs can cause these atherosclerosis. Ischemic heart disease can be caused by atherosclerosis in coronary arteries. And that happens when blood supply to our cardiac tissue is deficient, meaning there may be a blockage of a coronary artery causing reduction of blood flow to our very important cardiac tissue. This can increase lactic acid in the area because it can cause our cardiac tissue to require anaerobic respiration, and so it can often be accompanied with angina pectoris, which would be chest pain. So ischemic heart disease is detectable by looking at someone's ECG and being able to read the difference between the ST segment of the ECG. This is when there should be depolarization and then repolarization of the cardiac tissue, and there may be impact of that if there is reduced blood flow. Myocardial infarction is a heart attack, and that can usually be caused by blockage of a coronary artery. And that can impact heart muscle, where if cardiac muscle is not getting the oxygen it needs, it can die. So it's diagnosed by high levels of creatine phosphokinase and lactate dehydrogenase. I think we've mentioned this in another video where plasma troponin is actually another indicator of damaged muscle. So that is another way to diagnose myocardial infarction. Dead cells here are replaced by a non-contractile scar tissue, which is not good news either. The last thing we'll talk about are arrhythmias. Arrhythmia is just an abnormal heart rhythm. First off, anything below 60 beats per minute is considered bradycardia. Anything above 100 beats per minute is considered tachycardia. And in flutter, when you have a heart flutter, contraction rates can actually be as high as 200 to 300 beats per minute. Sounds scary. In fibrillation, that is just an uneven or uncoordinated contraction of your myocardial cells, and that it makes your myocardium and heart pumping ineffective. Ventricular fibrillation is life-threatening because we need our ventricles to be able to push oxygenated blood through the rest of the body. And maybe you've seen those defibrillators at a hospital. An electrical defibrillator can actually reset or resynchronize the heart by depolarizing all the cells at the same time to kind of get that action potentials by the SA node reset and restarted again to hopefully recover the uncoordinated heart contractions.